And so I'd like to start off by introducing Dr. John Lunz, who is the lab director with the Transplant Immunology Lab in Tampa, Florida at LifeLink. He's been in the field for over 15 years, so a lot of experience, and I think we'll have a really good discussion today. Thank you so much.
So I'd like to welcome everybody to this One Lambda's user group meeting here, which really starts to talk about a little bit of a changing landscape and adapting laboratory practices to some new ways that things are actually being done. So we've got three esteemed colleagues that we'd like to first announce who they are. So Dr. Ahmed Mostafa, Dr. Kelley Hitchman, and Dr. Cathi Murphey will be talking to you about their perspectives on how the landscape's changing and how we really adapt to it. So the first speaker today is Dr. Ahmed Mostafa. He has his medical degree and residency in diagnostic laboratory medicine. In December of 2013, he graduated from Memorial University in Newfoundland, Canada, with his PhD in immunology and infectious disease. Thereafter, he went to the University of Calgary, also in Canada, for 2 years of a postdoctoral clinical training in histocompatibility and immunogenetics at the Alberta Precision Laboratory. In 2019, he was granted his diplomat from the American Board of Histocompatibility and Immunogenetics, and he is now the clinical director of the Histocompatibility Laboratory in St. Paul's Hospital in Saskatoon, Canada. So we welcome Dr. Mostafa up here, and he'll be talking to us today about the AllType FASTplex version 2, or in their HLA labs experience using those testing. So we welcome Dr. Mostafa up to the lectern.
Thank you. Okay. First, I would like to thank the organizer for giving me the opportunity to share some of the experience of our lab with the AllType FASTplex. So this is my disclosure slide. So actually, I divided my presentation into three objectives. So first, I'm going to touch base on the AllType FASTplex version 1, which we initially started our validation. And then I'm going to move into the AllType FASTplex version 2. And then I'll wrap up my presentation at the end by giving an alternative method for the version 2. So please keep tuned. So before implementation of our NGS, we used to do our HLA typing through depending on the category. So for solid organs, we used to do low resolution beads for HLA A, B, C, DR, and 3, 4, 5. And then we use the high definition SSO beads for the DQ and the DP. For bone marrow transplant, we used to do SSO by using the XR beads for HLA A, B, C, DR, and then SSO low resolution for 3, 4, 5, and SSO high definition for DQ and DP. So based on this typing method, this is how our report was looking like. You can see very nice high resolution typing at the top. But when you look at our disclaimer at the bottom of the report, you can see all the non-excluded alleles that we currently cannot resolve using this method. And with the implementation of the CIWD version 3, even with our current method, there was some other new alleles that has been in the new CIWD that we cannot resolve. And I highlighted this in yellow, as you can see in the presentation here. So this means that our method that we were using was become an outdated method, and we have to move on and carry on with NGS. So this is just the timeline of the when we started to implement the NGS. It took us 18 months from start to finish, but the actual validation only took 3 months. So if there is a new lab and they are thinking of implementing NGS and they want to implement it in the next 2 years, so this is the time when you have to start the negotiation with your institute. And the main you have to start also negotiation with your IT, because at the beginning I thought that IT is just one person, but then it became a committee, and there was over 20 people from different IT departments: security, safety, certificates, storage, applications, like a lot. So, and you have to convince the 20 of them that your product is safe and secure for the patient health and system. So we did the validation using 320 sample from our stored DNA bank, which is equivalent approximately to 640 alleles. We did allele frequency, so to make sure that we cover 80% of the normal population. And as you can see here in the table, this is the discordant that we could find. We found comparing our older method to the NGS method. And you can see that our old method was just basically SSO and SSP, so we were lucky to get this this number 5 alleles. So in this table, this is just some of the discordant that we find using the new method. So with AllType FASTplex, as an example, it was typed as 00201 and 0224. When we compare it to our reference method, it was actually 001 and 002. And then when we looked back into the SSO run, which was done 2 years ago, we found that this was actually a sample carryover in SSO, and we had to make a corrective report after 2 years. The next one is AllType FASTplex gave us an A0201 and 3101 null. Even using the SSP trace, which can resolve this rare null alleles, we were not able to resolve it. And then when I contacted the vendor who supplied us with the SSP, they said, we just supplied the primer, but we cannot guarantee that it's going to work with every single rare allele. So even if the SSP tray saying that they can resolve this allele, they'd never validate it in their company, because there is this allele probably maybe have been seen once or twice. So it's very difficult to get a patient having this rare allele. The third example here was an example of an allele dropout, which is somehow common with any NGS. So when compared the reference method has actually found an DR beta 01 and 04. And when we repeated the same sample again, we were able to rescue this allele dropout. And we found that the DNA quality that we initially used was not a very good quality. So it's important when you do an NGS is the quality of your DNA, because if you have a bad quality of DNA, then this is when you start to get some issues. The last example here was the DP2301. It was homozygous by FASTplex AllType. With our older method, it was heterozygous 0401 and 2301. And then when we went back to the string, we found that the actual 0401 was one of the rare allele. 0401, I think it was like 04168 or something like this. And then in the same string was the 2301, and the technologist just picked the first one and was reported as this. So we went and we did another corrective report. And then we said, we're gonna stop now, otherwise we're gonna start fixing all our reports. So the conclusion of objective one, that AllType FASTplex provided more than 99% concordance with our reference method, and MiniSeq provided a solution for small lab, size lab, HLA lab that is interested in NGS implementation in more economical, or if there is a tight budget. So with every limitation, with every technique, there is some limitation. So the limitation in the version 1, that it didn't sequence exon 1. And when you look at the alleles that are present in exon 1 and for the class 2, you can see there is a number of alleles here. Most of these alleles are very rare alleles that you don't have to exclude. But DR beta 1, 1210 is a common one. So most of the lab who are using this technique either can report it as a 1201 P or a G group. The other limitation here is the version 1 used the dual index strategy, which is basically consists of two barcoding. You put your barcodes on either ends of your fragments, and it's the I7 and the I5. And I'm not sure it's just keeping moving by itself. So One Lambda usually supply the I7 barcoding in a form of 96 well, but only the first 3 wells, the 3 rows, columns are filled with the barcode, and this actually column are sufficient for 96 samples. And in order to make available for 96 samples, the I5 barcode is in a different format, which is in tubes, so you can mix between I5 and the universal barcode in order to cover the 96 unique barcoding. So, and this was not an issue for our lab, since our lab is more like a small to medium-sized lab, because we only do 24 samples per run. So we never use, we never have to use 4 different pooling. We only did the example on the right side here, which is just we do 1 pool. This will be maybe more with big size lab when they do 48 samples or a 96, then they have to do 4 pools, and then after they do the 4 pools and they attach the barcoding, then they can pool them again back into 1 sample. So this comes to the objective 2, because One Lambda was listening to this recommendation, so they started to add in version 2 sequence of exon 1. So this actually solved all these alleles that we cannot solve with exon 1. And it comes as a supplementary primer, so you can just spike, it's the same technique as the other one. You just spike your primer, mix with it, and you can now sequence exon 1 for class 2, DR, DQ, and DP. The other difference in version 2 now, instead, and this is actually for the bigger lab, that you don't have to pool into 4 different tubes. Now you can pool them into 1 pool, because now they have a redesigned sample, an universal barcode that can have 96 unique library sampling. So in concordance, we tested this, I think this product just launched last week. So we didn't have enough to run, but we ran 24 sample, and we got, like, as you can see here, 100% concordance when we compared it to version 1. We just noticed that comparing version 2 to version 1, the total reads, we noticed that the total number of reads on the DR and the DQ and the DP locus was significantly higher in version 2. So I'm assuming this is because of the addition of exon 1. And then when we looked at the length of the read, the length of the read was mostly the same. Depth of the read was mostly the same between most of the loci except the DQ. And then when you look at the specifically in exon 1 of DQ, I haven't seen this number before. We have got a depth of read of 5500x. So when you look at the like the histogram, so what you see here, what you see in purple, this is the exon. So the first exon is exon 1, and then exon 2, 3, and 4, and 6. And you can see that the number of reads in exon 1 is significantly higher than the rest of the exon. So it just gives you an uniformity reads, but at the end it doesn't affect your call, because although you have 5,500 depth in exon 1, but you still have from 300 to 1400 depths in the rest of the exons. So the conclusion of objective 2 that the FASTplex version 2 provided 100% concordance comparing it to version 1. It solved the exon 1 ambiguity in HLA class 2. And now it's the issue for big labs. Now you can pull the sample only into one, using only one single tube. So this brings into the objective 3, which is using the version 2 but do some modification. And this was done in collaboration with One Lambda. It was one of the feedback that we wanted to reduce the hands-on time. And One Lambda actually recommended to us to use this alternative protocol. And we were one of the labs that did this beta testing. So this is actually the normal protocol that we use in our lab. And this is not the recommended timeline of One Lambda, but this is the timeline that fits our staff and fits the workflow. So in day 1, usually we start in the afternoon by the long-range PCR, leave it overnight, and then the next day we do the purification, and then the quantification, then the diluting, barcoding, and then pooling, and then we stop here in day 2, and then take it to day 3, which is quantification and then sequencing. And the reason, although like One Lambda used to recommend that we can do it in one day, we found by the end of the day our technologies get exhausted, and the last step has a lot of calculations, so we decided just to move it to the next day, extra 2 hours, but you can guarantee a better result. And then in day 4, you do the analysis on the TSV, and then interfacing it with histotrack, and then by day 5, you can start reporting. So it's a 5 days turnaround time. So using the alternative protocol is based on recommendation of One Lambda that this purification step can be omitted. So we actually tested this and we were able to omit this purification step. So by omitting this purification step, we were able to combine day 2 and day 3 into one day, because in the purification step, you need to prepare your ethanol, you need to equilibrate your magnets, you need to, everything have to be room temperature, which takes some time during the beginning of the day, although it's not hands-on time, but the tech has to wait until all the reagent is reached the room temperature. So when we eliminated this step, the technologists can just take the plate and then just quantify directly and then start on going on to the rest of the day. So by using this alternative method, we were able to reduce the turnaround time into only 4 days. But One Lambda recommended, in order to use this, you need a very high quality DNA. And you know, I usually like to challenge One Lambda, so I sneaked one of the buccal swab. As you can see here, this is actually a tape station, if you're not familiar with this one. It's like running your DNA on a gel, but it's more like a microchip. So you can see here sample number 6 has a little bit faint band, and this was a buccal swab. And usually a good genomic DNA, you would have a big chunk of DNA at a very high molecular weight, above 60 kb. And if you can see the last 2 samples, there is a little bit of smear because there is some degradation, but still most of the samples are in above the 60. And then what we did is we compared the 2 assays, which is the purified and the non-purified, and then the product or the amplicon, we run them again onto a tap station. So this is actually the tap station after the amplification of the purified, which is the recommended method. And you can see here, now you have 4 bands. So the top band represents your main amplicon. The 3 small bands is the exon 1 amplification for DR, DQ, and dPeter, because this is the version 2. And then the lower band here, which is very faint, is the primer dimer, which same as what you see when you run an SSP gel. And then when we use the alternative protocol, which is the unpurified protocol, we still can get the same trend. You can still get the higher band and the 3 bands. But if you look at the bottom, you can see a big chunk of primer dimer because we didn't purify it. So this primer dimer is going to carry on with your experiment. But when we did the concordance, actually it gave us a very excellent result. We got 100% concordance between the version 1 using the recommended method and using the alternative method. We just noticed 3 samples out of the 24, which I highlighted here, has slightly higher background. Like for example, the first one, the A25, there is 20% of your reads were just noise or background. But if you look at the majority of the code, which is almost 80%, you have 542 depth. So it's sufficient to give you confidence that the C is the right code. And the same scenario for when with the DQ alpha A1. The last example here, it was a split. So it was not just a high background, but when it reached the 50-50, then the software considered this as a novel allele. But because the number of reads is only, I think, like 22 and 21, so we know that this is not a novel allele, and this sample just needs to be repeated. The other thing we notice with this alternative method is that exon 6 usually have less number of reads, but when we use this alternative method, it has more or less of reads, and then it results in one of the ambiguity that we use. We have seen it in most of the sample when it's typed by DQ beta 03, which is, it just cannot resolve the 03454, which is a very rare alleles. So in conclusion of this objective 3, AllType FASTplex version 2 alternative method provided 100% concordance with the recommended protocol. It's a very promising tool to reduce hands-on time, but still some work is needed to complete it and to become clinically validated. At the end, I'd like to acknowledge the HIL lab staff and especially Destiny Webster. So she's the second from the right who did all this work, and I'm here only just to present it. And also I would like to thank One Lambda for giving us this opportunity, and I'll be happy to answer questions.
So our next speaker is Dr. Kelley Hitchman. Dr. Hitchman joined the University of Texas Health San Antonio Department of Pathology and Laboratory Medicine as an assistant professor in 2016. And she serves as the section chief, director, and clinical consultant of the HLA lab at University Hospital. She completed her PhD in immunobiology at Iowa State University, and then pursued a postdoctoral fellowship at the Moffitt Cancer Center in lovely Tampa, Florida. After that, she then joined the Northwestern Laboratory as a histocompatibility and immunogenetics fellowship trainee, and she completed that in 2016. Dr. Hitchman is board certified by the American Board of Histocompatibility in Immunogenetics and is a wonderful speaker. So today she will be talking to us about filling the gaps, the UT Health San Antonio experience with the ExPlex beads. So we get to hear a lovely talk about how using some new technology and to be able to help us refine our antibody call. So I welcome Dr. Hitchman to the podium.
Thank you, John, for such a lovely introduction. I'd especially like to thank Peter and Jed Barger, One Lambda, and Thermo Fisher for allowing me to speak today and share with you our experience with investigating and eventually bringing ExPlex testing to our testing menu at San Antonio. So what I'm going to go over today basically was our rationale for the utility of the potential for the testing with ExPlex beads, which is a different iteration, an additional iteration of lab screen single antigen testing. I'll just refer to it as ExPlex from here on out. The options that you have that we utilized at least for validation and some of the intricacies in analytics and interpretation that we've found since we onboarded ExPlex. So I don't know if any of you were there or saw it, but about a year ago, I was giving a talk at ASHI 2020 virtual meeting about HLA DSA monitoring and how we work so hard pre-transplant to prevent HLA DSA from occurring, but we all know it happens despite our best efforts, and that's still the ultimate battle, right? So this is our foundational tool, single antigen bead testing on a Luminex platform. Undoubtedly and arguably has revolutionized our ability to detect and identify antibody production and patterns in our patients. And this is one of the base panels, both class 1 and class 2. The big question that we always ask, though, is this foundational tool really enough for us to do a good job when we're virtual cross-matching? And beyond that, when your patient is post-transplant, is this tool really enough to make you feel confident and make your clinicians feel confident that you're detecting what you need to post-transplant to keep your patient safe or give accurate assessments of the current immunologic picture of your patient? So thinking about that foundation, for us in San Antonio, kind of always are thinking about what can we do differently, can we do better. And I'm sure it hasn't escaped your attention that there are a lot of HLA alleles out there. There's a lot of possibility, right? So when you look at the tool that we have, and you look at the number of HLA alleles that are possible, it's kind of overwhelming to think about. When I have fellows or residents come through the lab for their rotations, I always give them the same spiel. You know, HLA is the most polymorphic system in humanity, and they kind of give me this glazed over look, and I'm like, okay, let's bring it back. Let me make that more tangible for you. There are lots of different antigen groups in HLA, right? So one of those is A2. Well, there are well over 700 different flavors of just A2. And then their eyes get real big, like, yeah, there you are, now you're with me, okay? So when we think about the amount of protein variability that's possible, we look at common well-documented 2.0, and we think to ourselves, well, it's okay, because at least most of those aren't really commonly seen. Then, of course, common intermediate well-documented 3.0 comes out and broadens that picture. So maybe now we're not quite so comfortable. But then you look at P and G group definitions, you're like, okay, these things are we've still got some things that are similar. But still, our antibody testing coverage is nowhere near what's possible. And then you look at papers like this paper that was published in Human Immunology in 2017. If you look at panel C and D at the bottom, in this paper, their T-cell and B-cell flow cytometric cross-matches show absolutely horrible correlation with their detection of anti-HLA donor-specific antibodies. So they kind of dug into that. And they found that 56% of their virtual cross-match failures were likely linked to false negative single antigen testing. And they realized that maybe a potential criticism of their work would be that maybe prozone is what's contributing to that. So they actually took their samples and performed 1 to 10 dilutions to try to uncover a little bit of prozone, and were able to do so in several cases. But prozone didn't explain the total picture. They went on to find that in several of their patients, by using supplemental antibody panels, some of those supplemental targets that were not on the base panel detected additional donor-specific antibodies that were correlate with their cross-match outcomes. So this paper really laid the majority of their virtual cross-match failures on the holes in their single antigen testing without using supplementary panels. So we have this similar concern in San Antonio, Texas. We are a majority Hispanic Latino population, and our population is growing by leaps and bounds every year. I myself am a transplant to San Antonio and absolutely love it. I can absolutely understand why people move there en masse. And as you can see from our 2019 census data, San Antonio is in Bexar County. It's not spelled that way, but that's how it's pronounced. And in Bexar County, we have a very high rate of foreign-born immigration. So our population is expanding, and it's expanding to become more diverse. And so in South Central Texas, these are some of the HLA alleles that I see very commonly in my patient and my donor typing. And none of these alleles are represented on the base antibody detection panel that I utilize. So right there is a problem. My patients and my donors are in a gap. They're in a place that I can't really definitively say I can see them when I'm testing for antibodies. So what about alternative panels? You do have options out there. You've got Luminex mixed beads, which do represent some of those other antigens, but that's less sensitivity and specificity than single antigen identification. You've got the FlowPRA, same issue, and you've got supplemental panels, which is great. But it means that I'm going to have to run another test. I'm already running tons of tests. I'm going to have to run another test. So then I go to a regional meeting, and along comes ExPlex. So this assay was unique to me, something that I had not seen before, in that it's a single antigen bead platform. So it has the sensitivity and specificity of single antigen identification, but it's not a separate test. It is a separate panel, but you're spiking it into the test that you're already running. So you're really not running a separate analytic test. And the workflow that is suggested by One Lambda Thermo Fisher is down there at the bottom of the screen. So this capitalizes further too on the utility of the LabScan 3D instrumentation. We have room for 500 beads, and we don't even come close to using that with most assays. But if you combine ExPlex with the base panels, you have a total of 151 class 1 beads and 119 class 2 beads. So not only do we utilize the instrumentation more to its capacity, we still have room to grow if we need to. So, in addition to that, as I'm looking what ExPlex offers, it is directly pertinent to my patient population. Highlighted there in yellow are some of the class 1 targets that I extremely frequently see in my patient and donor pool. And highlighted there in yellow are some very frequent targets that I see in my class 2 patient and donor pool. So I'm thinking as I look at this, I've got these patients and donors in this gap. My population's growing, it's diversifying, and then if you think about March and the allocation change that happened, broader sharing is on the horizon. So not only is my local population becoming more diverse, the donors that are going to come across my door are also going to be diverse outside of my population. So this is very intriguing to us at this point. Another thing that I like to point out is in our analysis, we're always trying to determine what is real. And one tool that I love to use to do that is the presence of G group and P group beads on these panels. When those beads that are genetically identical react apart, it's a good cause for concern, or at least an indication that you should look a little bit more closely at the validity of the data. And so these add some additional beads to allow you to extend that type of scrutiny to your analysis. So we chose to evaluate ExPlex for all of our solid organ patients, both pre and post-transplant. ExPlex covers many alleles that we see in our population, but I'm also thinking broader sharing, right? Because I'm going to start getting donors that don't represent my patient population at all. So a very fair question is, why in the world would you do this both pre and post-transplant? Post-transplant, you know the donor type, maybe the donor isn't any of those things. Why run that extra test? Why spend that extra money? Why do that? And my thought is that every antibody that's legitimately detected is a DSA waiting to happen. That's absolutely true pre-transplant, but even post-transplant. What if your patients end up back on the list? You need good data to inform those virtual cross-matches of the future. So when we were ready to start validating this test and really putting it under scrutiny, we wanted to know, what is the proper serum bead ratio that we should be using when we're adding this additional bead component into our assay? We wanted to know about the utility in patients of differing antibody abundance and range, reproducibility, interaction with serum treatments. We do treat our serum samples with EDTA, and on occasion, we use adsorb out beads for high background treatment. And do we find what we suspect? I think every single one of us sees serologically similar beads stacking together, and you try to fill those gaps in your mind, right? I've got all the DQ6s, except I don't have a bead for that one DQ6. But if all the other ones are there, that one's there too, probably, right? Isn't it? So we can put that to the test. So we chose to take 30 patient samples, previously characterized by standard single antigen panels, a range of sensitizations, and samples that required differing serum treatments. We tested 4 bead serum combinations against the original test that was run, but we also reran the test baseline in parallel to account for any freeze-thaw differential, technical differential, all of those things that we know contribute to variability in our single antigen testing. And this is what the data looks like. I know we don't have time to go through it bead by bead, such as I did, as interesting as it was. So let's look at maybe zooming in on one of the patients in the study. So we found overall preservation of our previously detected specificities. If you look to the immediate right of the specificity listed, that is the normalized MFI value of the original test. To the right of that is the normalized MFI value of the repeat baseline single antigen panel. To the right of that is your 30 microliters of serum with ExPlex beads and single antigen. To the right of that is 35 microliters of serum, and to the right of that is 40 microliters of serum. So kind of surprisingly, we saw some diminishments in MFIs with the higher amounts of serum in our population. Overwhelmingly, we had the best concordance with 30 microliters of serum in the system. So we saw reasonable pattern preservation. We saw preservation overall of weak specificity detection. We did see some surprises, and we also saw some I told you so's. In this particular patient, if you look at the ExPlex beads that were added in for class 2, kind of just take you back here for a second so you can see this patient has some DR4 stacking. This patient has a couple of the DR14s, but not all of them in the baseline panel, and has the DR53 beads reacting. When you look at the ExPlex beads added in, some of those patterns carry forward. We have DR4 reactivity in the ExPlex beads at that same week range, but not all of them. We do have additional DR14 reactivity, and so on and so forth. So there were some surprises, and there were some I told you so's. Those are probably there. And we can't go through data point by data point. This is kind of what the data for about 5 of the patients in the data collection looked like. And this is just to highlight to you that the groupings of the 5 runs of patient data were pretty tight. If you tried to look at the whole thing at once, you'd go cross-eyed. It looks kind of like this. But you can see we chose patients with a variety of reactivity ranges, and the groupings were on the whole pretty tight, pretty repeatable. So like I said, we ended up choosing 2.5 microliters of single antigen beads, 2.5 microliters of ExPlex beads incubated with 30 microliters of serum. This seemed to give us the best preservation in data and the best overall sensitivity. We do use baseline the rapid version of this test, and that's why we didn't immediately start with 5 microliters of serum as the One Lambda baseline protocol suggests. Overall, and this was based on the most conservative assessment, we saw about 85% concordance in the data at this level. And this is in comparison to the non-ExPlex parallel data for each individual bead. Most of the variability that we saw was actually between the original run and the baseline run repeated, which for some of these samples was several years and freeze thaws later. So phase 2, we had to do a reproducibility and instrument comparison test with that chosen optimal serum bead ratio. So we took as many of the samples that we had remaining as we could from phase 1, and we ran them on the 3 Luminex 3D instruments that we had in the lab, and we showed 96% concordance between instruments and about 90% concordance with the phase 1 data. So we approved the validation in December of 2020 and immediately went live, and since we've done a little over 9,000 antibody identification tests with ExPlex beads. So I'm going to start with the negative. Be totally transparent in this talk about the rosy and the not so rosy. The only con that we've really seen is non-specific binding. And to give you an example of what this looks like, in our experience with ExPlex, we have a lot of C-specific, especially C17, non-specific binding. And it usually is in combination with non-specific binding that we see in the base panel too. So this is a patient that has a really, really broad C-stack. Top ranking bead is A1102. Anybody else ever seen that? And you can see highlighted in the patient's raw data all the ExPlex beads that are represented in that reactivity. This is the flow PRA screen for that patient. I will say that there's great representation of most of those positive beads on the flow PRA panel. Here's a class 2 example, a little bit scarier looking. This patient has a real tight DQ5, DQ6 stack with really robust reactivity. And so that new bead, DQ alpha 0101 and DQ beta 0503 is included in that reactivity panel. When we run the flow PRA on this patient, we get pretty much nothing. And when we do a surrogate cross-match with a DQ alpha 0101, DQ beta 0501 patient, we get bubkiss. And that's our top rank bead. So this is negative. So the pros, let's get to those because those are much more numerous. We have had several pre-transplant catches without reflex testing because of the ExPlex panel. We get better, more accurate virtual cross-matching out of this panel. We have had several post-transplant catches. Basically, our patient went from having no DSA to all of a sudden having DSA because we could test for it. So that has happened in a few circumstances. So we went from having to estimate reactivity based on the serologic equivalence of DSA that was present on the base panel to actual DSA detection. Here's an example. Thank goodness for DQ5, DQ alpha 0101, DQ beta 0503. We had a little girl who needed a kidney. Her grandmother wanted to come forward for her. Her grandmother was a DQ alpha 0101, DQ beta 0503, and a DR14. So you can see there the little girl's antibody pattern detects no DR14 that we would be concerned about, but all the other DQ5 beads that are present on the panel, the 2 that are there on the base panel, are positive. So we have a really strong suspicion that this girl is probably making antibodies to the other DQ5 as well, but we don't know for sure because we don't have a bead for that. So in this circumstance, without that bead, without ExPlex, I would have to do another separate test requiring either a draw from the donor or a draw from a surrogate donor to get at that 0101, 0503. But now I don't have to do that because we ran ExPlex on this little girl, and here are the additional ExPlex beads from that little girl's sample, and indeed the DQ 0101, 0503 is there. So thanks to this ability to test with these additional beads, I don't need to go to the donor and ask them for a sample, which causes a lot of emotional impact and questioning in the donor and patient. I don't have to wait for that sample. I don't have to perform an additional test. I don't have to find a surrogate donor to do a cross-match. So, in summary, ExPlex has lifted many of our patients out of the single antigen gap that we all see. It had many targets we needed. It was flexible. It did not decrease our ability to detect weak antibodies. It confirmed our suspicions in many circumstances. It has no greater issues than baseline panels and nonspecific binding, but it is there. Overall, ExPlex saves us time and resources. I especially want to thank the University Hospital HLA Laboratory, especially my super techs, my technical supervisor, Princess Alexis George, and my super tech, Janet Franco, who were instrumental in getting all of this validation work done and collected. Thank you.
So to follow up on those first two wonderful talks, we next have Dr. Cathi Murphey. Dr. Murphey is the Histocompatibility and Immunogenetics Laboratory Director of the Southwest Diagnostics Incorporated in San Antonio. So luckily for us, we get representation from both histocompatibility labs in San Antonio today. She has a ton of experience within the field. As we all know, Dr. Murphey is also the current past chair of the UNOS Histocompatibility Committee and a terrific mentor for those of us who are following in her footsteps in that committee. She also currently serves on the UNOS Kidney Committee, where there's a lot of activity in being able to forward kind of the new changes that are coming up in kidney allocation, as we all probably know about. To note also, Dr. Murphey is also partners with Dr. Adam Bingaman to run the largest single center kidney paired donor exchange in the country. And so she's got a tremendous amount of experience, especially in kidney transplantation. And today she's going to wrap up the talks discussing the UNOS kidney allocation and the evolving landscape that is in place today. So, Dr. Murphey?
Thank you, John, and also I'd like to thank One Lambda for inviting me to speak today. So I'm going to divide my talk up into two different sections. In the first section, I'm going to talk about the current kidney allocation system, and I'm going to show you some data of how well it's working or if it's not working. And then I'd like to switch gears and talk about what the kidney allocation system may look like in the future. So just to give you a little bit of background, so you know that the current allocation system went into effect in March 15th of 2021. Initially, it was supposed to go into effect in December of 2020, but that got pushed off until March. And the effect of this new allocation system was to remove the allocating point from the current donor service area, or DSA, into a concentric circle. So we had some debate about the size of the concentric circle, and so after public comment and a lot of feedback from the regions, it was decided that the nautical mile circle would be 250 miles. And what happened is that proximity points are assigned to the closest point in the proximity circle located to the donor hospital. So this shifted away from the OPO area and the allocation within that DSA to the donor hospital. So now these circles starts at the donor hospital, and patients that are closest to that donor hospital actually get additional proximity points, and then all the way out to this end of the circle where there's no proximity points that are added. And additionally, this increased priority for pediatric patients and for prior living donors. So you can see over here that in the first sequences that before, the prior living donors weren't given as high a priority, nor were the pediatric population. So inside, especially sequence B, the pediatric populations popped up in priority, as well as the prior living donors. And there's some other policy changes. I'm not going to dwell too much on those about medical urgency and then recovery systems for the donors that were in Alaska. So what the data that I'm going to show you today is divided into the pre-implementation era, which was January 15th through March 14th, and then the post-implementation area, which is March 15th through May 14th. And the metrics that we use to monitor this are the waiting list trends, transplant trends, and donor utilization. I'm not going to show you all of it, but I'm going to show you some of the very pertinent points of the data and how well the new, or didn't, the new allocation system work. So first we wanted to look at the number of deceased donor transplants. Did that go up or did that go down? So in the blue bars to your left, this is the pre-implementation period, and this is transplants by week, average number of transplants by week. And in direct contrast to the right in the green bars are the average number of transplants in the post-implementation area. And so you can clearly see that the donor transplant rate actually increased in the new implementation era versus the old implementation era by average of 343 to 390 transplants. Next, we wanted to divide it by region and see were all the regions created equal. And if you remember, I don't know if you remember the KP-SAM modeling that came out, and there was a big controversy about the modeling and how it was going to work for this particular situation. But what you can see is by region that in the majority of the regions, 7 out of 11, the average number of transplants actually went up. And those regions that the transplant numbers went down, which is like region 1, region 2, and region 10, those were modeled by KP-SAM to decrease. So interestingly, the data for the first 3 months show that the modeling was fairly accurate. Next, we wanted to look at the number of transplants, the average of transplants by recipient age. Since we gave more points to the pediatric groups, that you would expect to find that the pediatric transplant rate increased, and indeed it did. So again, the blue bars are the pre-implementation, the green bars are the post, and what you can see is that the number of pediatric transplants, the average, increased from about 10 to 15 transplants per week. And again, this was across all populations. So in every group, age group, the number of transplants went up in the new implementation era. So importantly, we needed to go back and look at race and ethnicity, because one of the points that was brought up was, will this disadvantage certain populations? And we wanted to make sure that we were not implementing a system that would disadvantage minority populations or other populations that might be disproportionately disadvantaged. So when we went to look at this, what we can see is that the groups that increased the number of transplants the most was Hispanics. So they saw an average increase from 64 transplants per week to 84 transplants per week. The next group that had an increase in transplantation was the Black group, Black recipients, and they increased from 116 transplants to 132. So again, this showed that the modeling by KP-SAM held true and was accurate for the impact that this allocation system would have on our patients. When we went to look at CPRA, what we saw is that there was an increase in the number of transplants per week in the CPRA group from 80 to 98%. If we look at a little more granular level, the 80 to 94 increased from 16 to 31 transplants per week, and in the 95 to 98 from 7 transplants to almost 22 transplants per week. So this was a great increase for our patients that are disadvantaged due to sensitization status. Now, not surprisingly to anybody in this room is, where did these kidneys come from and who's getting transplanted with the local donors versus non-local donors? So the top graph represents the numbers of our patients on an average, weekly average, that are being transplanted with local donors versus non-local donors, which is a graph on the bottom. So you could see that we went from about increase of a quarter of our donors coming from non-local sources to about 2/3 of our donors coming from non-local sources. So, but interestingly, and I don't have time to show all the data today, that while they're not coming from our local DSA anymore, they are coming from within the 250 nautical mile circle. So they're not outside of that region. So the modeling for that circle turned out to be extremely accurate. So importantly, I think that one of the major concerns that we heard from our colleagues in our community during the regional meetings and during public comment period is that it was theorized that the discard rate would go up due to inefficiencies of organ placement and just travel of the organs in general. But what we see is post-implementation that the discard rate is fairly flat. It did not go up, and it actually decreased slightly after the policy was implemented. So this was significant and in two different areas. One, we can share more broadly without having our discard rate go up, and that the KP-SAM modeling was actually very accurate. So now if you want to look at discard rate by KDPI, what you can see is that the lower KDPIs were relatively flat. But interestingly, in the highest KDPI, the 86 to 100%, the discard rate actually went down. So, and this was another area of concern for our community, is that these harder to place organs, or the organs that may be just a little bit more marginally acceptable, might be disadvantaged, and they would be discarded at a higher rate. But the data show, at least within the first 3 months of the data, show that this did not hold out to be true. So in conclusions, what we saw is that the transplant volumes increased, particularly in the pediatric population, also in the Black and the Hispanic candidates. I didn't show this data, but it also increased in the higher dialysis time candidates. The CPRA group were transplanted at a higher rate. The discard rate did not increase and actually decreased slightly. And while the more kidneys are distributed outside of the local area, they were maintained within the 250 nautical mile circle. And it also shows that the KP-SAM modeling that was used to develop this policy was very accurate. So now I'd like to shift gears and talk a little bit about what's on the horizon for us and the new continuous distribution. And I'd be very interested to hear about the effect of the current allocation system on their laboratories, and then what they think that this continuous distribution might bring for them as well. I can tell you that in my own laboratory, one of the things that we saw almost immediately was an increase in virtual cross-matching. Who else had a lot of virtual cross-matching? Right? I know, because if you're outside of your local DSA, you're going to get more offers, and so you're going to have to vet these patients without being able to get samples in to do prospective cross-matches. So the continuous distribution was a system will replace the current classification system-based point system with a points-based system. So this actually aligns with the original OPTN final rule. So what we want to try and do is make this system a little bit more equitable and have more access to transplantation for our patients. And as we sit right now, I'm going to show you a little bit of this, is that within our classification system, you don't move to another classification system until you've allocated to every patient that's in the first system. So this is going to actually do away with the hard boundaries and will replace with a composite score that's made up of these different goals that have been assigned to kidney allocation. Then they're medical urgency, post-transplant survival, candidate biology, patient access, and placement efficiency. So the rationale for this, as I mentioned, was to have a more equitable approach, to remove the hard boundaries that are associated with this classification-based system and replace it with a composite score that will be derived from attributes, and within each attribute there will be a different points assigned to each attribute, and this will make a composite score for our patient. This will establish a system that's flexible enough to work for each organ type. That doesn't mean that every attribute is going to be the same for every organ, or that the weighting score will be the same, but they will have the same basic system. And this system will make future changes in policy faster. And if you have any expertise or any involvement with UNOS, you know that everything in the UNOS moves extremely slow. So hopefully, if we need to make changes, we can make them at a little bit faster pace. So here's what the current state versus the future state would look like. On your left-hand side is our current classification-based system. And as I was alluding to, is that if you are a patient in group 1 or you're a patient in group 3, you do not get access to that organ until every patient in group 1 has been offered the kidney, and then it goes to every patient in group 2, and so on and so forth. So if you're down in the 5th or 6th classification system, the likelihood of you having a specific offer is slim. Now, if you move to the points-based system on the right, each one of these colored bars indicates an attribute. And within that attribute, you're assigned a particular score based on your clinical data of each patient. So they're added all together, and you can see that not all of them are weighted the same. They don't have the same score for the same attribute, but the composite score at the end shows you the patient that will be on the top of the list, and all patients are ranked together. So, and it's all based on this composite score. So where are we now with this? Well, if you had an opportunity to look at the concept paper that was put out by the work group, this is out for public comment right now. So the public comment period is from August 15th until October 15th. And I highly recommend everybody take a look at that concept paper, look and see what attributes are there and everything that's being proposed by the work group, and give feedback, because it's really important to make your voice heard in this important topic in the new allocation. And where we stand right now is we're working on converting the attributes into points, and then this will follow this process along. So the goals that have been identified for the new kidney allocation system are medical urgency, post-transplant survival, candidate biology, patient access, and placement efficiency. So for medical urgency, that's kind of self-explanatory. For post-transplant survival, we want to increase the life of the graft by matching appropriate donor and recipient pairs. For candidate biology, we want to increase opportunities for patients that are medically harder to match. We want to have all patients have the appropriate access to transplant. And then we need to consider the resources that are required to match and transport, because it's not inconsiderate the amount of resources that go into transporting organs. So within each one of these goals is the attributes that I mentioned. So for medical urgency, again, it's just that definition, and this just went out for public comment last year, so this will probably stay the same. Within post-transplant survival, we're looking at HLA matching, the EPTS of the patients, and the ischemic time. For candidate biology, we're looking at blood types and CPRA. For patient access, prior living donors, pediatric population, the safety net that's going to be put in place for the simultaneous liver-kidney transplants, and the waiting time. And of course, placement efficiency is travel efficiency, proximity, dual versus single, and en-bloc transplantation. So now that we've defined these attributes, we have to devise a rating scale and a weighting scale. So the rating scale refers to where the patient is going to fall within a particular attribute. So for example, CPRA, we know that that's a sliding scale right now, so it will continue to be a sliding scale. And that's how we're going to rate these patients. The patients that are 99.9 are going to receive more points than the patients that are CPRA of 20%. The weighting refers to how the attributes are going to be weighted against each other. So is a placement efficiency going to be rated as the same as candidate biology? Will medical urgency be rated higher than candidate biology? So all of these factors need to be taken into consideration when we're making rating scores and weights. So So just to give you some, this has gone back and forth, and it takes a lot of meetings. We've been meeting for over a year and a half to try and pinpoint how we're going to assign points, both for the attributes and how the weighting score of how the attributes will be weighted against each other. So this is preliminarily what we've established so far. The CPRA will be a steep nonlinear scale. I think that what we saw, and all of us in this room know this extremely well, that maybe we gave a little bit too many points to the patients that are 99.5. Maybe we should give some more points to the patients that are 99.9. We know that those patients wait the longest, that even giving them more points doesn't get them transplanted. The denominator needs to be bigger. But so maybe to even everything else out, maybe the CPRA needs to be, the points need to be changed. Oops. For blood group, we're working on maybe assigning more points for blood group O patients, and of course, probably no points for blood group AB patients. So there may be some wiggle room, and we have to kind of come up with that. For pediatrics, this is kind of going to be a yes or no, so it's binary. If you are a pediatric patient, you'll get 1 point. If you're not, you get no points. So, and that's true for both kidney and for pancreas. And then HLA matching, and this was the most interesting to me because we decided that we needed to look at the data to see if HLA matching, number one, should it even be included into any kind of attribute? And number two, if so, what are we going to assign points for? We know that we get points now for DR matching, but in the literature, if you look at all the literature that's been out there lately, you think, well, maybe we should shift our points and look at DQ instead of just DR. So we had to go back to the data to actually look at this. So what we did was look at all the different loci independently, and then we looked at some together, such as a DQ and DR. But what we found was that independently, none of the loci except DR had any impact on graft survival. And then when we went back and looked at DQ, that had relatively no more impact than B locus. And actually, the B locus had a slightly more impact on graft survival than DQ. And so now we're back to looking at possibly giving points for DR matching. And this is, we're still up in the air. How much should that count? And importantly, are we going to disadvantage populations for assigning points for DRs? For those that are rare phenotypes, are they going to be disadvantaged if we are assigning points by DRs? Well, I can tell you right off the top of the head, one of the groups that will be disadvantaged, and that's anybody who's homozygous for DR. So automatically, you're going to be out at least 1 point if we're assigning points for matching. So there's a lot to think about when we start to assign points for that. And then prior living donors, that's, again, it's just a binary yes or no to assign points for that. So we built the attributes, we've discussed those, we're going to work on the rating scale and the weighting scale to determine how we're going to rate these and how we're going to weight them. And then we're going to build and we're going to adjust. We're going to do modeling, we're going to send it out for public comment again. We expect to get a lot of feedback from the community and see how this looks and how this might look in the future. And then this is just to give you a timeline because this will happen. It's not a question of if it's going to happen, but when. So we began working this in the August of 2020. We put the concept paper out, like I mentioned. It's out for public comment right now. So I hope invite everybody in here to make a comment. That closes in October. We'll take all the feedback that we get from the public comments and all the regional meetings and all the data that we get, and we'll collate that back into the attributes and the weighting and the rating scales. We'll update the paper. We'll put that back out for public comment, so you'll have an opportunity to look at that and comment it again. It'll go out to the regional meetings and out to the community. And then once it comes back with the final draft, it'll go to the board for approval. And then once the board of directors approves it, then it'll be implemented. And this should happen within 2023. So I'd just like to leave you with a couple of questions and something to think about is what should equitable allocation look like? Because I don't know, with something as scarce a resource as donors and kidneys, We have to balance equity versus access, because equity does not equal access. And so we have to decide where we are going to fall in that scale and how that's going to impact our patients, and is this the right system for our patients? And with that, I would be happy to take any questions.